Welcome back, everyone, for another deep dive. Today, we're going to tackle breast reconstruction after breast cancer surgery.
One of the big things that we always think about as surgeons, right, is the timing and all the options available to us.
Yeah, absolutely. I mean, that's the first decision point, isn't it? Immediate or delayed reconstruction. So many factors are involved.
Right. And I think for me, one of the biggest things, as a surgeon, you're always trying to think about what's best for the patient, what are they going to benefit most from. And so with immediate reconstruction, just the idea that the patient wakes up and they have a breast mound right there, that can be so powerful. And thinking about all the methods we have to offer, we've got silicone gel implants you can put in prepectoral, subpectoral. We've also got that whole toolbox of autologous tissue transfers like the latissimus dorsiflap, tram flap, the anterolateral side flap. Yeah, and thinking about the autologous options, I mean, the DIEP flap has really become like the go-to for a lot of us, especially over here in the UK. I think the tissue quality is reliable. You're preserving muscle function. It's a really good choice. But, you've got to respect the microvascular demands, and you're looking at a 4-hour operation, give or take.
Yeah, for sure, for sure. So when you're thinking about, okay, well, maybe delayed reconstruction is going to be a better option, when is that really coming into play?
Yeah, I think, oftentimes if adjuvant therapies are needed, like radiotherapy, then a delayed approach makes more sense. And usually you'd be looking at reconstruction about 6 to 12 months after they've finished those treatments.
Gotcha, gotcha. Okay, so let's kind of shift gears a little bit and really think about, what are the techniques themselves? And let's kind of categorize it by, okay, what was the initial surgery? So let's say we're dealing with someone who had breast conservation therapy. What are our main goals for reconstruction in those patients?
Well, in those cases, you're usually talking about oncoplasty techniques.
Mm.
And you've got two main types there. Volume displacement, which is basically rearranging the existing breast tissue. And then you've got volume replacement, where you're adding tissue to the breast.
And with that volume replacement, what are the different things we can do there?
So, for smaller volume deficits, you could consider autologous fat grafting. But for larger defects, then you're looking at flaps. Could be a skin flap, muscle flap like latissimus dorsi, a fascia flap to improve contour, or even a combination of flaps when you need to address multiple issues.
Right. Okay, so now let's switch over and say, okay, well, what about the patients who need a mastectomy? What are our sort of like big picture approaches to reconstruction in those cases?
So broadly speaking, for mastectomy patients, you're considering either expander implant-based reconstruction or autologous reconstruction using the patient's own tissues.
Okay, so with autologous reconstruction after mastectomy, what are the main places we're getting that tissue from?
The abdomen is the workhorse, right?
Yeah.
So DDOP flap, the tram flap. The latissimus dorsi flap is another one we use a lot because it's so versatile. And then, there are other sites we can consider depending on the patient's anatomy and their goals.
Yeah.
And sometimes you might even do a combined approach, using some autologous tissue plus an implant.
That makes sense. Now, one of the things that always sort of plays a big role in our decision making is radiotherapy. We know some patients are going to need it. So what are the specific risks that we need to be really aware of when it comes to radiotherapy, especially when we're thinking about implant-based reconstruction, particularly with the silicone prostheses?
All the data and just our experience shows that there's a much higher risk of capsular contracture when silicone implants are exposed to radiation.
Mm-hmm.
And that often leads to, results that aren't aesthetically pleasing and even some potential complications.
Yeah, definitely. Now, I think one thing we haven't really touched on yet is symmetry, right? Because at the end of the day, that's one of the big things that patients are looking for. So what kinds of procedures might we need to do on the opposite breast to get that symmetrical look?
So yeah, for symmetry, we often have to think about doing something on the other side. Maybe a reduction mammoplasty, an augmentation, or a mastopexy, a breast lift. And it's really important that we talk to the patient beforehand and explain that they might need more than one operation to get that symmetry they're looking for.
Yeah, setting expectations is key. Well, we've covered a lot of ground here. The timing, the options, the role of radiotherapy, the importance of symmetry. It's a complex field, and it's always evolving and getting better, offering even more solutions to help our patients.
Absolutely. And, at the end of the day, what we want is to ensure the best possible oncological outcome, but also help women feel whole again, both physically and emotionally.
Well said. Thank you for listening to our podcast. See you in the next episode.